Good afternoon, everyone. Welcome to the Two Rivers Public Health Department Measles Webinar for 2024. My name is Jackie Haley, and I am the Clinical Section Manager at Two Rivers, and I get the pleasure of leading this Measles webinar. First off, a little information about Two Rivers Public Health Department. We currently cover 7 counties, which include Buffalo, Dawson, Phelps, Kearney, Harlan, Franklin, and Gosper, for a grand total of 4,624 square miles and a population of 97,519. Here are Two Rivers' mission and vision. In summation, healthier communities for all. The next 2 slides introduce you to our TRPHD team. First up is our leadership team. We are led by our health director, Jeremy Eshelman, which you will hear from shortly. And we have 4 managers to support our health director. These include Arvin Menon, epidemiologist, Jackie Haley, clinical services manager, Jesse Valenti, finance manager, Katie Mulligan, planning section manager, and we currently have our community health manager position open. In addition, our nursing team, which I oversee. We have 5 community health nurses, in which 5 are RNs and 2 program nurses, which are LPNs, and 1 billing specialist. Now to welcome you to this measles webinar is Jeremy Eshelman, Two Rivers Health Director.
Thank you, Jackie. You can hear me okay?
Yep.
Okay, great. Thanks everybody for making time to jump on this afternoon. Just ran in from outside really quick, and what a beautiful day outside. So we're here today to talk about measles, and it's something that I think in the communicable disease world we're all aware of, but fortunately for us, we haven't seen an active case of measles, in at least in our jurisdiction for quite some time. And I'm talking probably decades. We had a scare back when I first started as health director. I think it was back in 2015, 2016, but turned out to be a false positive, something tangentially related. But nonetheless, measles is one of our more communicable diseases, actually highly communicable diseases. And the risk really comes down to vaccination. And if there's a history of vaccination, at least if somebody has been vaccinated with the 2-dose series, the risk goes significantly down. And then what we're seeing across our nation right now, and Jackie's going to get into some specific statistics, it is little pockets of measles, that outbreaks that are occurring, small clusters. That being said, it's something we're watching, we're being very vigilant about, because the reality is in the world that's connected today, we could see a case of measles within our jurisdiction. So Jackie's going to really detail the biology of and the virology of measles a little bit, and kind of just a quick refresher. And then we're fortunate we have a few guest speakers with us. We have Dr. Donahue, Matt Donahue is a state epidemiologist. He's going to we had a conflict with the schedule, but he's gracious enough to do a quick recording. And with us also, we have Miss Tana, legal counsel for Two Rivers, but she's also a renowned public health attorney. So she's going to be talking about some legalities of quarantine isolation, the law regarding all things communicable disease, if that's fair, Tana. So you'll hear from her in just a little bit. So otherwise, one thing I want to allude to is it's easy with any communicable disease, such as measles, to make the quick assumption and judgment that measles is caused because of immigrants coming into our country. The hard fact is right now that 95% of all cases are coming from U.S. citizens that have traveled abroad. And they usually represent with a history of no history of vaccination or under vaccination status, so only 1 instead of 2. And so we're seeing this being brought into the United States from other countries where measles is endemic. And unfortunately, it's hitting certain subpopulations that are under vaccinated. And so on the flip side, the good news is in Nebraska, and in our district in Two Rivers, we are above the state average on MMR, measles, mumps, rubella vaccinations. And as a state, we are above the threshold for herd immunity, which is 95%. So I don't want to steal a bunch of your time, Jackie, but thank you for setting this up. And I think let's go forward with it.
Thanks, Jeremy. Our first topic today is background information, where we will define the measles virus etiology, including signs and symptoms, transmission, treatment, and a brief history. To define measles, it is an acute vaccine-preventable viral respiratory illness, and humans are the only natural hosts. Signs and symptoms of measles are fever as high as 105 degrees Fahrenheit, malaise, the 3 C's, which are cough, coryza, or a runny nose, and conjunctivitis. Koplik spots followed by maculopapular rash, which appear 14 days after a person is exposed and spreads from head to toe. Next, we will look at the transmission of measles. Measles is spread through the air. You are contagious 4 days before symptoms begin to 4 days after the rash appears. Measles is one of the most contagious diseases, with 9 out of 10 susceptible persons with close contact developing measles. And the air and surfaces remain infectious for up to 2 hours after the infected person leaves. As for treatment, there's no specific antiviral therapy for measles. Medical care is supportive and focuses on relief of symptoms and reduction of complications. Let's move on to who is at risk for measles. People at high risk for severe illness and complications are infants and children aged less than 5 years, adults aged less than 20 years, pregnant women, and people with compromised immune systems. Airborne precautions are used for bacteria or viruses that are transmitted through small respiratory droplets. These droplets are expelled when someone sneezes, coughs, laughs, or otherwise exhales in some way. This is why we will isolate the patient for 4 days after they develop the measles rash and utilize respiratory protection with an N95 respirator. To illustrate the complexity of measles infection, 1 to 3 out of 1,000 people with measles will die, even with the best care. Additionally, some other astonishing facts regarding measles infection are: measles is a vaccine-preventable disease. 1 person with measles can infect 12 to 18 people, making it one of the most infectious diseases. About 1 in 5 people in the United States who get measles will be hospitalized. And in 2022, measles infected an estimated 9 million. Let's move on to the history of measles. In 1978, the CDC set the goal to eliminate measles by 1982. While this goal was not met by 1981, there was a decrease in measles cases by 80% when compared to the previous year. Through the widespread implementation of the MMR, or measles, mumps, rubella vaccine, the United States was declared measles-free in 2000. The WHO defines measles elimination as the absence of endemic measles virus transmission in a defined geographical area for at least 12 months in the presence of a surveillance system that has been verified to be performing well. The United States is on the brink of losing this measles-free status. As of April 4th, 2024, a total of 113 measles cases were reported by 18 jurisdictions. These include Arizona, California, Florida, Georgia, Illinois, Indiana, Louisiana, Maryland, Michigan, Minnesota, Missouri, New Jersey, New York City, New York State, Ohio, Pennsylvania, Virginia, and Washington. There have been 7 outbreaks defined as 3 or more related cases reported in 2024. And 73% of cases, which is 83 of 113, are outbreak associated. For comparison, 4 outbreaks were reported during 2023, and 48% of the cases, or 28 out of 58, were outbreak associated. Of these, 56 cases were under 5 years old. 26 cases fall in the 5 to 19-year-old category, and 31 cases fall in the 20-plus-year-old category. 83% are unvaccinated or unknown, 12% had 1 dose of MMR, and 5% had 2 doses of MMR. 58% of the cases, or 63 out of 113 cases, have been hospitalized for management of measles complication. This is why it is imperative that we start talking and have plans in place for a measles outbreak in Nebraska. Now we will hear from Dr. Matt Donahue, epidemiologist for the state of Nebraska. Dr. Donahue is unable to be here in person today, but he has so graciously sent us a recording of him discussing his slides, where he provides an overview of the current measles situation.
Hello all, it's a pleasure to bring you some measles updates in this pre-recorded video. I was planning on joining y'all last week and then that meeting was rescheduled to today and I had some vacation plans. So apologies for not being here, at least virtually in person. Happy to take questions though through email if any of you have some for me. My email's at the very end of this.
Sorry about that, guys. I was notified that you guys weren't hearing him, so I fixed it, and now we will roll.
Hello all, it's a pleasure to bring you some measles updates in this pre-recorded video. I was planning on joining y'all last week and then that meeting was rescheduled to today and I had some vacation plans. So apologies for not being here, at least virtually in person. Happy to take questions though through email if any of you have some for me. My email's at the very end of this presentation. Let's start with one of the most contagious diseases around here, measles, and jump into it a little bit. So I never really liked this movie at all. You all know what this is. This girl's like turning into a blueberry or whatever it was. This scared me when I was little, and this movie still continues giving me the scares now, mostly because of this quote. So Roald Dahl, this was the author of Willy Wonka, The Chocolate Factory, James the Giant Peach. He gives us this testimony. Olivia, my eldest daughter, caught measles when she was 7. As the illness took its usual course, I can remember reading to her often in bed and not feeling particularly alarmed about it. Then one morning, while she was well on the road to recovery, I was sitting on her bed, showing her how to fashion little animals out of colored pipe cleaners, and when it came her turn to make one herself, I noticed her fingers and her mind were not working well together, and she couldn't do anything. "Are you feeling all right?" I asked her. "I feel sleepy," she said. In an hour, she was unconscious, and in 12 hours, she was dead. And that terrifies me as a parent to a 1-year-old and a 3-year-old. That would be absolutely horrifying. So measles isn't something to just shrug off. It's nothing to worry about. Prior to 1963, which is when vaccine became widely available, nearly 50,000 people were hospitalized each year. 1,000 had encephalitis or swelling of the brain each year, and 400 to 500 people died annually. Today, 1 in 5 people in the U.S. who get measles are hospitalized. 1 out of every 1,000 children with measles develop encephalitis, which can lead to brain damage and permanent disability. And 1 to 3 out of every 1,000 children with measles will die, even with good medical care today. So far this year, the U.S. has produced 64 cases across 17 jurisdictions, and that's more than what was produced through all 12 months of last year. We're simply seeing more cases earlier this year, and it looks like it'll be another high year. Now, the reason why this is getting health officials' attention is normally when we see a high year, it's because of a specific outbreak. But this year, it looks like it's spread pretty much all over throughout the whole U.S. And this is happening while, year over year, we're seeing MMR immunization levels drop nationwide from 95% to 94% to 93% of school entry or kindergartners immunized last year. More cases, widespread, not just one outbreak, lower immunization levels. This has all of us paying attention. So although measles was eliminated from the U.S. in 2000, meaning we no longer saw local cases crop up on their own, we are now seeing multiple cases in each of these jurisdictions, originating with travelers and spreading among the unvaccinated. Take a close look at this map. We're not far off from measles cases ourselves here in Nebraska. Fortunately, Nebraska is toward the top of the pack for school entry or kindergartner MMR vaccine levels. We're at about 95% of our kindergartners vaccinated, but we dropped from 96% last year. We need to ensure we don't drop further. And you can see we're fast approaching that red bar, which includes states that are below the estimated herd immunity threshold of 95%. So the only strategy here is to proceed as if we will have measles, to count on it. To prepare, we put out a measles press release with some basic information. We've updated FAQs on our DHHS website. We've pre-positioned vaccine, and we're ensuring we know how to access immunoglobulin in the state if we need it. We've planned with our close partners, including our local health departments and our healthcare coalitions. And more than this, if we get a case, we've prepped a press release, a risk assessment, a health alert network alert. We've prepped our active monitoring system and a tool called REDCap, and an exposure self-identification tool there as well. We've prepped with our local EPIs in our local health departments how to do measles case investigations and contact tracing. And we're even training up a special outbreak response team in case we need to reinforce local health departments if we have a sizable outbreak. Louis Pasteur said chance favors the prepared, and we intend on being as prepared as we can. Now, for physicians or healthcare providers, nurses, for healthcare in general on this call, there's probably 6 main things that you need to know now. You need to ensure you know how to test for measles if you think you have a case. That might be through NewAlert to NPHL. That might be through your existing EMR. You might already have a pathway to do a send-out test for measles. You need to know how to test for it. And that will include both a nasopharyngeal PCR, that'll include a urine PCR, and that'll also include blood for an IgM. Make sure you know how to order those tests whatever mode you might order it through. Know how to check titers. We might send you a patient who needs to have their titers checked. That's somebody who's exposed to measles and say, no, I have a record of immunization, they just can't find it. We might need to check some IgG titers on that patient. Please know how to do that. Help patients find their childhood immunization records if they ask you ahead of time. Immunize pediatric patients early if they're traveling. So CDC and their HAN put out some really good information about this. Normally we immunize patients when they're 12 to 15 months old, and then again when they're 4 to 6 years old. But let's say you have someone 6 months to a year. You have an infant between 6 months and a year, and that family is going to be traveling internationally. You can give them a dose early. And that's really important. That might help prevent them from getting measles abroad. Let's say you have a kid who got their first dose and they're between, say, 1 and 4 years old. If they're in that range prior to them being able to get their second dose normally, they can get that second dose early if they're traveling internationally. Be aware of that, and please offer and recommend that if your patient's traveling internationally. Be ready to isolate a patient and to test them in clinic, in an emergency department, or in urgent care, anywhere you might see them. We're asking patients to call ahead if they think they have measles, to give you a heads up ahead of time. Be ready to isolate and test. Know what you will do in your practice, clinic, urgent care, or ED if you have someone show up who suspects they've been exposed or have measles. And just as important as the rest, know your local health department contact. Your local health departments will help you navigate each of these situations and scenarios. They're a direct connection to us at the state and to CDC if needed. Know your local health department contact and have them on speed dial. And guys, that's all I have for now. If you have any questions, feel free to email me. I'm at Matthew, MATTHEW, .Donahue, DONAHUE, at nebraska.gov. And Nebraska is spelled out there. Please use your local health department resources and contacts. Feel free to email me. In addition, happy to help and happy to help get us all prepared for measles just in case. Thanks much. Bye-bye.
Thank you, Dr. Donahue. He left us with a beautiful segue into our next topic, communication strategy, where we will discuss coordinated communication plans to ensure that accurate and timely information about the measles outbreak is shared with clinicians across the district. First off, communication is the key. Communication between local public health agencies and clinicians is essential for ensuring the health and safety of the community at large. If Nebraska starts to see any measles infections, we will send out notification to our district. This is where we will start thinking defensively and start having conversations. If our district has an outbreak of measles infections, the plan will be straightforward. We will coordinate measles outbreak campaigns and provide timely updates. We will establish regular Zoom calls or in-person meetings and send feedback or evaluations. Two Rivers will focus on providing trainings, resource sharing data, and surveillance information in real time so everyone is up to date. To prepare for measles outbreak, we will need to designate liaisons, develop joint communication plans, and establish emergency communication protocols. By implementing these communication strategies, our strong partnerships will promote health and well-being of the community. There are many graphics available to post. These will encourage conversation around measles. As we know, measles is a vaccine-preventable disease. So, the best defense is to ensure we are educating on MMR vaccinations and when and where they can receive these. The CDC provides resources available for you or your staff to learn more about effective vaccine conversations. This includes guidance for talking with parents about vaccines, tips to prepare for questions parents may ask about vaccines, vaccine safety sheets, and the You Call the Shots MMR module. In addition, the CDC has examples of resources for providers to utilize. These include immunization schedules, fact sheets, and infographics. I am including the following links as these are great resources and can provide talking points and give general knowledge, along with printable resources that we are able to share. Let's move on to vaccination campaign. Here we will discuss strategies to promote measles vaccination within communities, including outreach efforts to encourage vaccination uptake among patients who have not yet been vaccinated. As I previously stated, measles infection is a vaccine-preventable disease. This vaccine is safe, effective, and has been available for over 50 years. Measles vaccine has saved more than 57 million lives worldwide between 2000 and 2002. The 2 recommended doses of measles and rubella vaccine cost less than $2 per child. And 1 dose of MMR vaccine is about 93% effective, as 2 doses of MMR vaccine are about 97% effective at preventing a measles infection. There is no scientific link between vaccines and autism. Furthermore, scientists in the United States and other countries have carefully studied the MMR shot. No studies have found a link between autism and the MMR vaccine. Most health plans cover the cost of the MMR vaccination, and if they do not, there are programs called Vaccines for Children and Vaccines for Adults to help if someone has no insurance or are underinsured. It is always better to prevent a disease than to treat one after it occurs. As previously stated, vaccination for measles is safe, highly effective, and a cost-effective way to help keep your family and friends healthy. The recommended vaccination schedule balances when a child is likely to be exposed to a disease and when a vaccine will be most effective. Vaccines are tested to ensure they can be given safely and effectively at the recommended ages. All vaccinations have a Vaccine Information Statement, or VIS. This explains both the benefits and the risks of a vaccine, and the VIS is offered when you receive any vaccine. Finally, when to vaccinate your child. Children are recommended to receive 2 doses of the MMR vaccine. The first dose is recommended for 12 to 15-month-old children, and the second dose is recommended for 4 to 6-year-olds. Additionally, there are also catch-up schedules for unvaccinated children and adults. It is recommended that people who were born during or after 1957 and do not have evidence of immunity against measles should get at least 1 dose of MMR vaccine. Luckily, Two Rivers and most primary care physicians have VFC and or a VFA program, along with private vaccinations. If you identify someone in need, they can see their primary care physician, or you can refer them to Two Rivers Public Health Department for vaccination. Now, we will switch gears and discuss legal resources. I'd like to introduce Tana, attorney at law. She will identify resources and materials that can be distributed to educate about legal resources in relation to measles.
Thank you, Jackie. It's great to be with you all today. What I wanted to do is basically provide you all with some resources that would be useful to you in your clinical practices and help you know where to turn if there's anything that you need in the event of a measles outbreak. So to start off, I wanted to give you just a couple of statutes. Obviously, these are not the entirety of the code as it relates to public health. There's a whole host of statutes, but I wanted to point out just a couple of them, which is the authority to prevent the introduction and spread of contagious infections and malignant diseases, and that authority to enforce and enact regulations is given to both local public public health departments through the first statute that you see on the screen, but also to DHHS through their general supervision and control when it comes to issues of quarantine and whatnot. So that's where the authority ultimately comes from, that local public health departments and Nebraska DHHS would be exercising. Next slide, please. Okay, so what I have on the slide here are just a few key points from a particular document that's put out by the CDC. This was last updated in July of 2019, and looking, I don't see that it's been updated since then, but I would anticipate if there are continued to be measles outbreaks, that this likely would be updated at some point in the not too distant future. Essentially, this particular document has a series of recommendations. There are 7 of them to deal with prevention and control of measles, particularly in healthcare settings. And so I just wanted to briefly go through what those recommendations are. And then you can also see the link is on your screen too, if you wanted to access the entirety of this particular document. It's about 12 pages, but it has fairly good sized margins and isn't too terribly dense of reading. So first off, the first recommendation is to ensure that all healthcare professionals have presumptive evidence of immunity to measles. And you can see that there are a couple of different ways that that can occur, either through vaccination, lab evidence of immunity, lab confirmation of disease, or birth before 1957. But even with birth before 1957, the recommendation is still essentially vaccination for those people who may have been born before that time frame, if there's a measles outbreak that's occurring, just to essentially make sure that healthcare professionals are not putting themselves at unnecessary risk. The second recommendation is minimizing potential for measles exposures. And there are different recommendations for before a person arrives at a healthcare setting and upon their arrival at a healthcare setting. I'm sure a lot of these are not going to be particularly surprising to people, having been through a recent pandemic. But I would recommend essentially taking a look at what those recommendations are, because obviously they're somewhat different based off of just the way that measles in particular spreads and how contagious it is. Next slide, please. The third recommendation is adhering to standard and airborne precautions. And what I have here listed are different considerations for that. Again, that particular resource from the CDC has a lot of detail about how to take into consideration all of those issues, where placements, where patients are placed, if they have a known measles case or suspected to have measles, what healthcare professionals should do, what should be done if these patients have to be transported, how long the precautions have to be left in place, when and how visitors should be given access, and then implementation of other environmental infection control issues. The fourth recommendation has to do with managing measles exposures. And what I think is interesting here, and that I want to just highlight, is that there are different recommendations for those who've been exposed, those who've been infected, and for those where there's no presumptive immunity. So essentially, going back to their first recommendation, those who don't have written documentation of vaccine or lab evidence of immunity or lab confirmation of disease. Healthcare personnel are treated differently depending on essentially what their status is in this regard. The fifth recommendation is other considerations for a measles outbreak. And these are things like air filters and air discharge, and placement of patients in a cohort in the facility if they are confirmed to have measles, and how to separate those individuals from the rest of a hospital or clinic, and then other portable solutions that can be implemented for a brief period of time. So those, it didn't have a huge amount of detail, but it had some considerations. And then this particular document from the CDC also had some other documents essentially that they link to if these are things that need to be put into place with some additional, more detailed recommendations. The sixth recommendation is training and educating healthcare professionals and personnel, basically making sure people have N95 and that those have been fit tested, making sure that people are aware of how to prevent transmission of measles, and just other competency for PPE. The seventh and final recommendation in this report was establishing reporting with hospitals and public health authorities, which I think that the health department is doing a nice job of at least starting those conversations to work within this recommendation, making sure that you know who your contact people are within the health department. And then within healthcare facilities, making sure that you know essentially who which people are going to be designated to be essentially the contact people or the point people for communication between your healthcare facility and the public health department and the state of Nebraska. Next slide. So the next resource I want to highlight for you is the Nebraska Infection Control Assessment and Promotion Program Measles Resource for Clinics document. That's a mouthful, but this one was actually just updated about a month ago on March 1st of 2024. It specifically references the document that I just talked about and essentially says you should follow the recommendations from the CDC, which is not particularly surprising. But this is a nice little document that's not terribly long. It has some scenarios to kind of work through and basically make sure that you're thinking about how these scenarios would apply within your particular healthcare facility. It also has sample patient screening forms. It includes CDC signage. It includes log sheets that would be used for contact tracing. So in addition to essentially saying follow the CDC's recommendations, this document is really nice in that it gives you some actual kind of concrete resources that will be helpful in figuring out how to do those things. Next slide. The final document that I wanted to highlight for you is called the Nebraska Pandemic Bench Book. So this was authored by Chief Justice Michael Heavican, and there was a whole task force of folks that worked with him to put this together. You might be thinking, why in the heck do I need to read a book that's written by lawyers and judges and geared towards those folks? But bear with me. The reason that I recommend this is just because it has a really, really nice guide to how directed health measures in particular work. I think directed health measures are kind of confusing, just the way that the statutes are written and trying to figure out who can author them, who do they apply to, and those sorts of things. And we'll talk in more detail about that here in a moment. But this particular guide, which is available online, doesn't cost you anything. You can essentially download the PDF and look through it. I just think it does a really nice job of kind of making some of these really complicated things fairly simple and straightforward. This was authored in 2017. I can tell you I relied on it very heavily throughout the COVID pandemic. I'm not aware that it has been updated. So I would caution you that the back section of this particular document, the appendices where it lists contacts for the public health departments and things like that are going to be outdated, as well as the appendix that has bench books from other states also likely to be outdated. But again, if you're focusing on kind of the content section, very helpful. This also includes essentially the State Emergency Operations Plan and the Nebraska Emergency Act, and kind of gives some guidance about how those kinds of things work, as well as goes through what are some of the potential constitutional issues as it relates to quarantine and isolation. And then it also has some sample orders and documents so that you can see what some of those things might look like. Next slide. Okay, so directed health measures. This is where I kind of wanted to focus for just a few moments to make sure that people kind of have a good understanding of how this works. These are sort of complicated, and I recognize that we all have at least some understanding of them, having been through the COVID pandemic. However, I think that if we're talking about directed health measures in the measles area, that's going to look a whole lot different than it would with a novel type of disease that for which there's no vaccinations and no treatment protocols. In that during COVID, we all remembered directed health measures that were geared towards large groups of people. Directed health measures don't have to be closing down whole businesses or industries or things like that. They don't have to be geared towards large groups of people. They can and sometimes are geared towards individuals or small groups of people. So first and foremost, directed health measures are either issued by the State Department of Health and Human Services, the Chief Medical Officer, or through a local public health department. But if a local public health department is issuing a directed health measure, the state chief medical officer has to approve that before it's issued. There are a couple of potential exceptions. That would be Douglas County, Lincoln, Lancaster. The statutes sort of look like they carved them out, but there was some litigation pending during the pandemic about whether those could be issued over the disapproval from the state. And those were ultimately not resolved and were made moot by those directed health measures later being withdrawn. So I think those are open questions. For our part of the state, greater Nebraska, you can essentially expect that the state chief medical officer would be signing off on those directed health measures. There are multiple types of directed health measures: quarantine, isolation, decontamination. There are others that can include seizure of property, requiring that someone monitor and report their vital signs, requiring that people use particular PPE, and infection control measures. As I mentioned, these can be geared towards individual persons or groups of people or locations. And when I was looking back over materials for this presentation, apparently they can also apply to animals as well. So fun fact, not that that necessarily applies to measles. But essentially what you can see here is essentially they can be broad or they can be narrow as would be required by a particular circumstance. There are requirements in terms of what directed health measures have to include, the language that has to be in them. And there are also requirements in terms of what findings have to be made before a directed health measure can be put in place. I won't go through all of that. Just know that that information is in that pandemic bench book that I just referenced, and that's pulled directly from state statute. So when you see a whole laundry list of findings at the very outset of a directed health measure, that's why that information is there. The pandemic bench book also has some information in it that this would be more geared towards essentially a judge who may have to consider a challenge to a directed health measure, just some basic background information about measles, epidemiology, vaccine effectiveness, prognosis, treatment, complications, those sorts of things. That obviously is going to mirror the things that Jackie was just talking about just a few minutes ago. But know that essentially if there's a challenge to a directed health measure, that's going to go before a judge who presumably would be looking at this same resource and trying to figure out how to interpret a case involving directed health measure. There are essentially appeal process that's outlined in statute for those who don't want to follow directed health measures, think that they're unreasonable, those sorts of things. In the absence of following those types of protocols to appeal, a directed health measure is an order that can be lawfully issued by DHHS or local public health departments, and for which there would be criminal penalties for violating it. So if you are seeing measles cases or suspected measles cases, definitely follow the information that was in the previous slides. Make sure that you're reporting that to local and state public health departments so that appropriate actions can be taken by those entities to essentially protect the community from further spread and outbreak. Thank you.
Thank you, Tana. If there are specific questions for Tana, please put them in the chat or send me an email. We will answer some questions at the end of this webinar. If there are further questions, we will send a follow-up email with answers. So finally, we will discuss contingency planning. This is where I plant the seed for everyone to consider contingency measures. COCA released an emergency newsletter January 25th, 2024, called Stay Alert for Measles Care. This newsletter best outlines a contingency plan and provides recommendations for healthcare providers, such as isolate the patient, notify Two Rivers of potential measles infections, test the patient for measles. In coordination with Two Rivers, manage post-exposure prophylaxis of close contacts, while making sure all patients are up to date with the measles vaccination. In the event of a measles outbreak, Two Rivers will collaborate with clinicians to ensure the safety of all. This partnership will be a critical moment in our measles outbreak response. And finally, are there any questions at this time? I will unmute everybody in case there are. Anybody? We're ready to answer anything if you guys have questions. If not, I think I will give you guys almost 15 more minutes back to your schedules.
You know, Jackie, I'm always a man of many words, so I think I can always fill some time too. But just not taking more time than what we already have, but just really appreciate everybody taking time to plug in today to talk about measles. We are keeping our eye on a couple things that are globally, and the world's all connected globally more, as we all know. Monkeypox, we're watching that. That's not in the US right now, but there is a strain that's developing overseas that's a little bit more virulent and a much more concern. Also watching high pathogenic avian flu. Of course, that's always one of the things in the back of our mind that's of concern, just with everything we have going on, specifically in our area, the Central Nebraska Flyway with waterfowl and things of that nature. But as of this point in time, we don't have any cases in Nebraska. You know, we have worked a case that was suspect, but it was. I'd be quite surprised if it did turn out to be positive, just with all the circumstantial evidence about it. Otherwise, so there's always things in the communicable disease world, and as many of our clinicians online know today, it's always an interesting space to be in. So we really appreciate everyone's continued partnership, and if there's any other questions, you know, outside of measles or anything else in general, please let us know. We're here to help you in the work you're doing.
Thanks, Jeremy. All right. If there's no other questions, then we'll give you guys your time back, and we will see you guys at the next clinician's call. Thanks. Everybody have a great day.
Thank you.